Our next speaker is Dr. Jordan Gross. Dr. Gross is an assistant professor of radiology at the University of California, Los Angeles, in the Division of Musculoskeletal Imaging. Dr. Gross completed medical school at the George Washington University School of Medicine in Washington, D.C., radiology residency at Einstein Medical Center in Philadelphia, and a musculoskeletal imaging fellowship at UCLA. Dr. Gross has been published in multiple journals and serves as an editor for Radiographics and Journal of Ultrasound in Medicine. He is an active member of the American College of Radiology, Radiological Society of North America, the Society of Skeletal Radiology, and the Society of Radiologists and Ultrasound. He served as research committee chair for the SSR in 2019 through 2020. His research interests include many different areas and facets of musculoskeletal imaging. However, he's particularly interested in evaluating musculoskeletal neoplasms and neoplasm-like conditions, musculoskeletal interventions, and musculoskeletal ultrasound. Dr. Gross, welcome to the exchange.
Thank you so much, and thank you for the invitation. I am going to, hopefully you guys can all hear me, and
yes, we can hear you, and
you can see my screen, hopefully.
Yes, we can.
For having me here. My talk is going to be about imaging, kind of giving you a little bit of a background about what radiology even is and how you can become your own advocate in terms of your imaging and your imaging plan. So as Julie I'm just going to give you a little bit of background of my experience. Julie kind of mentioned it in my bio there. I did my residency at Einstein in Philadelphia, fellowship at UCLA, and then I've been at a couple of different institutions as an attending. And to kind of piggyback off of Dr. Dry, who I have the opportunity to work with in our multidisciplinary tumor boards, these locations, UCLA and Vanderbilt, have been what I call sarcoma centers, and where we, as Dr. Dry mentioned in her talk, it's a relatively, they're not super common. So to find an academic center where that really does specialize in sarcoma work, we have multiple sarcoma surgeons at our groups. And this allows the musculoskeletal imagers, the pathologists, to really all take an important part in your care. As Dr. Dry mentioned, we do weekly sarcoma conferences that are made up of surgeons, which include surgical oncologists, orthopedic oncologists, hematologists, oncologists, radiation oncologists, radiologists, pathologists. And it's really an opportunity for us to teach each other, to learn to kind of talk about some new research and medications, and from an imaging standpoint, to even talk about some novel imaging approaches. As a musculoskeletal radiologist, my area of interest is in the imaging of bones, joints, and soft tissues in the arms and the legs. I'm going to talk a little bit about the different modalities later in this talk, but as part of this specialization, I also focus in musculoskeletal tumor imaging, which can include multiple different types of sarcoma. One of the things I want to kind of emphasize, and I'm going to emphasize it again throughout the talk, is many academic centers will subdivide tumor imaging by body part, meaning if your sarcoma is within the abdomen in your belly, then that might be getting interpreted by somebody who specializes in abdominal imaging, versus if it's in an arm or a leg, that's going to get analyzed by a musculoskeletal radiologist. So you might see different names and different reports based on the type of body part that's being imaged. As radiologists, in an academic center, ideally you're being seen by colleagues within the same section, but you might have a different radiologist every time you get your scan. So what are we going to discuss today in the next 25 minutes or so? My objectives are to really tell you what a radiologist is. I have family members who still don't completely understand what I do. And what is the role in sarcoma care? What are the types of scans and imaging that can be part of the sarcoma workup? What happens from the time someone arrives at the imaging center for imaging to the time that the report is generated? What are the best practices for interpreting the radiology report? And who determines when, how, and what to image? So just again to, as the basic background, after medical school, doing a residency, there are two kind of subtypes within the world of radiology: interventional radiology, which has recently become its own residency program. That's a 6-year program. And diagnostic radiology, which is a 5-year program, often followed by a year fellowship, if not longer. And these are some of the different subspecializations that you can go into when you do your fellowship. So when we talk about this, it's kind of again repeating what I just said. If you're coming in with a head and neck mass, that's going to be reviewed by a neuroradiologist. If you're coming in with a leg mass, that's going to be reviewed by a musculoskeletal radiologist. And ideally, people who have had training at these kinds of sarcoma centers that will understand what we really need to think and talk about when it comes to evaluating masses. Again, workup might include multiple radiologists. So even if you have an upper extremity sarcoma, that will be reviewed by a musculoskeletal radiologist. But if you have a CT scan of your chest as part of a workup to look for metastatic disease, that's going to be reviewed by a thoracic or chest radiologist. And like I said before, I'm in a program with 8 colleagues who are musculoskeletal imagers. So if you come to us, I might read one of your scans, and then the next time you come, it might be one of my colleagues who reads your scans. But the idea is that hopefully the impression and your treatment plan should stay exactly the same, regardless of who's interpreting it. The way I break down interventional radiology and diagnostic radiology is interventional radiologists will often do they do a lot of procedures and sometimes biopsy. It's diagnostic radiologists, when you're at a big institution like ours, we also will do biopsies. So if you're coming to get a biopsy of your mass, you might be meeting a diagnostic radiologist, even though it's a procedure, or an interventional radiologist. I have a colleague who's an interventional radiologist who really likes doing rib biopsies. He's kind of become part of our section because some of my colleagues don't enjoy the rib biopsies so much. So when you meet somebody who's doing a biopsy that requires image guidance, that's a radiologist, and they can be coming from one of those two pathways. But the diagnostic radiologists are the ones that are going to be reviewing your imaging on a more regular basis. So I break down the diagnostic review of imaging into 2 categories: the first study, the first time we're ever imaging you, and the follow-up study. When we are looking at a first-time imaging study, our goals are outlined in this box to the left. We want to identify the mass, we want to describe what it looks like, and we want to provide measurements. We sometimes, I know I wrote not to give a diagnosis in bullet point number 2, we sometimes, when tumors look pretty classic, we'll give a diagnosis, but oftentimes, We do not give a diagnosis in our reports. That's because our goal is to maybe recommend biopsy or to then talk to the pathologists, like Dr. Dry was just mentioning, about are these findings concordant? It's not to come out swinging and say, this is exactly what this is. So don't expect necessarily a report that gives you a complete diagnosis that first time around. We describe number three is probably one of the most important things we do, where we describe the mass effect. What is the mass doing to really important structures? It allows us to provide a roadmap to the surgeons, the hematologists, oncologists, and the radiation oncologists about what is safe for your treatment plan. So this is an example. I'm not expecting I didn't put a ton of images in this presentation, but this is a mass at the back of the shoulder. And our goal here wasn't to say exactly what this mass is. Our goal was to say this is concerning enough to us that we think it should be biopsied. So the report just describes the mass, where it's located. It did get biopsied, and this was a pleomorphic sarcoma. To emphasize point number three, this is a mass in the posterior thigh. And again, it wasn't necessarily to say exactly what this mass was, but really what we wanted to do was to tell the referring providers, the surgeons, about its relationship to important structures. This little thing that's being circled in yellow is your sciatic nerve. So it's really important from our perspective to tell the referring provider, the surgeon, the radiation oncologist, where these structures are in relationship to the mass. That becomes part of our final report so that they know that if they go to take this out, that the sciatic nerve is sitting just on top of this lesion. That's where we really try to be helpful on your first imaging study. In the follow-up imaging study, so this is an example of a preoperative image, and this is a postoperative image. We really try to, we're essentially looking for new or recurrent tumor. Sometimes when we get, maybe the first image wasn't available, maybe this got done in an outside institution and that second opinion hasn't been uploaded into our system. But first time imaging is our best friend. What we want to look at is in terms of the original tumor, because if a tumor is going to come back, it's going to look pretty similar to what it looked like before. Anytime a tumor has been resected, then we call the new postoperative imaging study our baseline. And we will continue to compare these studies to each other to look for new tumor or what we call recurrent disease. Oftentimes in our report, we might say if, continued attention on follow-up imaging, usually that's at a time interval that's somewhat predetermined by our surgeons and by our sarcoma team. Or if there's something we're really suspicious for, we might recommend tissue sampling. So what types of scans might you be getting? This is we've got a lot of different types of imaging kind of within our armamentarium. Everything from plain film to nuclear medicine, breast imaging. There are some types of breast sarcomas that will occasionally become part of our sarcoma tumor boards. But these are pretty much a lot of our workhorses. None of my images here are going to necessarily show sarcoma cases, but really just to kind of familiarize yourself with what plain films and the other types of imaging modalities might look like when they come across to us. So plain films are 2D images that have an area of interest obtained using X-ray beams. They're kind of our basic unit in radiology. And in sarcoma workup, a plain film might be ordered specifically if the question is about a bone lesion. Plain films are really good to look at the matrix of the lesion, meaning is it made up of bone or is it made up of cartilage? We can also look at other signs on plain film, certain locations of tumors, if it's causing a reaction to the tissues around it. That can sometimes tell us that this lesion is aggressive, if there's a fracture through it. So plain films really do become our workhorse, but more often than not, if there is a tumor there, it's going to require additional imaging. Oftentimes, we'll get plain films in the post-operative setting, particularly if something has been resected and hardware has been put in. We want to make sure there's no hardware complication. And oftentimes other body parts. For instance, if there's concern for metastatic disease somewhere, you might get a chest X-ray or to evaluate for a port placement. If you have a soft tissue sarcoma, that might still get an X-ray, but oftentimes that will certainly get upgraded to additional imaging, more advanced imaging like CT or MRI. CT scans are more detailed or fancy X-rays. They use this, you get put into the CT scanner. They use a similar X-ray beam technology, but with a higher end. And then we kind of make 3D reformatted images so that we can look at these images in more than one plane. In addition, we can look at these in different types of windows. So these are lung windows where we can really nicely see the lungs, and this is what we call the coronal plane. So it's kind of almost directly looking at your chest. These are our soft tissue windows where we're looking, you can kind of see the subcutaneous tissues and the muscles, and this is kind of the same way we're acquiring these images with you laying down. CTs are really good with spatial resolution. And what that means is if you have two dots that are next to each other, CT is going to see those two dots really, really well, versus some of our other modalities where those two dots might look a little bit more blurred together. We often use CT to look for metastatic disease in the chest, abdomen, or pelvis, biopsies of tumors, or for musculoskeletal tumors, really to evaluate the bony architecture. Is this mass destroying bone? Because bony architecture is best seen on CT. MRI is a big workhorse for us in terms of sarcoma and tumor imaging. It does not use radiation. It's a different type of technology that uses magnets and radio waves. This is that same post-operative image that I showed you before. But what I wanted to point out here was one of the nice things about with MRI, we use external markers so that you direct the technologist to where it should go. And that's where we know the area of interest is. So we know to look just deep to that. MRI is good for contrast resolution. It's okay for spatial resolution for some things, but contrast resolution, we take multiple different types of sequences where things can look bright or they can look really dark. And MRI is very good at making things look either dark or bright. And those signal changes allow us to kind of help make a differential diagnosis or to really look at vessels and nerves. So MRI really does become a big workhorse for us. Again, signal characteristics of the tumor, which can help us figure out what the tumor might be, but again, might not go into the finalized report because it's a broad differential. Mass effect on close and adjacent structures, and it really does become a workhorse for us in terms of follow-up imaging. Ultrasound uses sound waves. What happens is we have a transducer. Those waves go from the area of interest to where the technologist or even the radiologist will put that transducer down over the area of interest. It sends sound waves, and then those sound waves come back up to the transducer. We use ultrasound a lot when we do biopsies, particularly soft tissue tumors, and we can really actually also look at if that tumor is vascular, if it's got color flow. But the real aid of ultrasound is to figure out if something is cystic or solid. That's what's really, you might have a bump that might be a ganglion cyst, which is a benign thing that doesn't really need much further workup, versus something that's a solid mass that might need further workup. Ultrasound is very good at telling the difference between those two things. So this is a ganglion cyst here, and this, which is outlined in these calipers, is a soft tissue mass that's just happened to be a benign lipoma. But ultrasound is really good to evaluate cystic versus solid. Not very good for bone lesions because sound waves cannot travel past bone. Nuclear medicine is also a big workhorse for us in terms of your workup. PET-CT is a commonly ordered test for oncologic imaging. Essentially, you might be in the radiology department for a few hours to get injected with a radio tracer. And the idea here is it's kind of a fusion imaging when we do PET-CTs. This is part of that nuclear medicine image. This is the CT, and this is the PET-CT result where we fuse these images. And the idea is really to look at the metabolic activity of the tumor or of the lesion. And that can also be followed. It gives us a quantitative number where we can see if treatment effects are working. We can kind of identify potentially new sites of disease, but really focusing on the metabolic activity of tumor. So if your doctor orders an imaging study, ask him or her why they're ordering it. Understand that not all imaging studies are created equal, and we recommend certain studies for certain clinical questions. But mostly, note that different types of sarcomas might have different presentations. So someone might have a soft tissue sarcoma, and they are down a completely different imaging pathway than a person who might be presenting with an osteosarcoma. So arriving for your scan and what happens after. So here's an X-ray. This is a CT scanner. You'll notice this tube is much thinner than this tube. This is an MRI. For those of you who've had MRIs, myself included, they can be really claustrophobic. But these are pretty much three of our bigger workhorse imaging modalities. And when you come to the imaging center, and you get called back for your imaging, the first person you're going to meet is the radiology technologist. They're going to perform the X-ray, CT, MRI, or ultrasound. These are some of my estimates about how long these studies will take. That doesn't mean that's how long you'll be at the imaging center. Sometimes it takes longer to check in and wait, but these studies take approximately about this much time. After you get your imaging, your images get sent to what we call our PACS. It's an archiving and communication system. And then the technologist will work on completing your study, and then it gets populated into a big list. Every different institution might have some different software that they use. At UCLA, our imaging lists are organized by body part. So as I was mentioning, the CT of the chest you have will go to the thoracic radiologists, whereas the MRI of the knee you have will come to our list. The radiologists might be reading your images at the location that you're getting your imaging at another site within for us for UCLA, or they could even be reading them from home. We have a lot of us, if not all of us, have imaging workstations at our house. When we open up your study, just know the more images, the CTs and MRIs, the more time intensive the interpretation. But when we open up your study, also your electronic medical record will populate in a different window. That allows us to read the notes from your hematologists, oncologists, your surgeons. It allows us to look at your labs, your pathology results, and really make a nice comprehensive report about what's going on. And it allows us to, it helps us in interpreting what your imaging. Your imaging jacket will also open. So those comparison studies that I was telling you about will get an imaging jacket that will show us all of your older imaging. And then we begin to generate a report based on our knowledge from what's in the electronic medical record. Once our evaluation is complete and the report is generated, we'll approve it in our dictation software program. If there's something stat, urgent, or unexpected, we can message your provider directly through the EMR, or it's often done through our multidisciplinary tumor boards or through the phone. You might see your report a few minutes after it's finalized. However, Dr. Dry mentioned some California state laws. Sometimes, and depending on the type of oncologic care you're getting, we might hold that report and give your oncologist the opportunity to go over it with you before we just send it out for you to see. And part of the reason is that our reports can sometimes be really confusing to understand, even for other physicians. I often tell my residents when they're first starting with us, radiology is a very different way to practice medicine, terminology that not every other physician uses. And so, they could be hard to read. And I think even for other physicians, it's always nice to go over the reports with the radiologists, particularly if they have questions. This is often the structures of my reports: history, comparison, the technique, how it was done, findings, and the impression, what we see in our recommendations for further management. So this is what one might look like, at least for me. I often divide my findings into oncologic findings and non-oncologic findings. And oftentimes I put the history directly into the findings of the report, answer specific clinical questions, like whether or not there's any new nodular or discrete soft tissue masses. And similarly, that's what's in my impression. No evidence of recurrent disease. And we might see you in another 6 months to make sure that things are still at bay. But talk to your primary care provider to help with the interpretation of report. I always say don't Google it, because Google can always make things seem it's easier to have a conversation with the physician, either the primary care provider, the surgeon, or even the radiologist. We have ways to potentially communicate with the radiologist at our site at UCLA. So if there are questions about your report, don't feel free to ask. So this is usually, like I said, how I break down my reports: and first-time imaging, follow-up imaging, just kind of a conclusion here. First-time imaging: is there a mass? What's the mass effect? What is it doing to neighboring structures? You might get a definitive diagnosis, pretty rare, but you could. And management options. Are we going to biopsy this? Are we going to watch it? And if you have you come back in 3 to 6 months? That's what you should be expecting with first-time imaging. Follow-up imaging, I break up into 3 categories. No evidence of tumor. We might see some evolving post-operative changes, and we might just want to watch it and make sure that things kind of calm down from any kind of post-treatment change. And the third is a new finding. That might require short-term follow-up imaging, maybe, like I said, in a couple months, or even maybe tissue sampling if we are concerned. And who determines when, how, and what to image? I would say this is, again, kind of the multidisciplinary conferences and the multidisciplinary approach. Each specialist takes part in the conversation. Surgeons will ask us when we think that patients should be re-imaged or if something needs to be re-imaged. They might push some additional imaging because clinically they're concerned. So your imaging plan is often either agreed to by an established practice of care, which we have some nationwide established practices of care, or consensus of your sarcoma care team. Usually when we make these imaging recommendations, it's often coming from one of those two approaches. So I believe that's all my time, but thank you so much for giving me the opportunity to speak with you today. And I'm happy to answer any questions you might have.
Thank you. That was so informative. And we do have a number of questions in the Q&A. I think we have time to answer or to ask a few of those live. I'll just pick a couple to ask you. But I just want to thank everybody for the great questions. I think the last two speakers are talking about topics that are actually difficult for patients to access information on. And so I think all of the great questions are a reflection of patient interest, combined with just it's sometimes difficult to access pathologists and radiologists to ask these questions directly. So sorry, I want to get to the top here. First question, how important is it to have the same institution do the scans so that they're consistent? Additionally, post-surgery, how difficult is it to identify a change, such as a recurrence, due to the complexity of looking at a radiated surgical site?
Yeah, those are great questions. The first question and the first part of that question. The institutions have the potential, particularly when we're talking about MRI, to do completely different protocols. So we do really like when patients continue to come to the same site. Does that mean that we can't look at old imaging, or if you go to multiple different sites, we can't put the clinical picture together? No, a lot of times for us, we're a sarcoma center, so patients might come down from Santa Barbara or even further, and getting imaging where we are can be somewhat complicated. So we can put it together, but it's always nice when we can actually have all of the imaging, then when we're comparing apples to apples. So when we know that we're doing the same protocol over and over again, it makes it a little bit easier for us to interpret. Does that mean we can't? No. If it's done differently, no. I would say it's important to get all of your imaging, so then that way we can really put the picture together. The second question about post-operative and post-radiation type of changes, it can be really difficult that very first time. We spend a lot of time looking at the pathology results, making sure there are negative margins. That sometimes really helps us in our interpretation. So things that might look distorted, we know there were negative margins, or if we know there were positive margins, we might be a little bit more concerned that there's still some tumor there. But that's kind of where, again, it's because that tissue can look so distorted, and it's supposed to in a surgical setting. It can be hard. That's why the follow-ups are really important. We won't let you go too far, at least in a sarcoma center, with the first time MRI. The second MRI will probably be just a few months later, just to make sure that those post-surgical changes are evolving correctly and that we're not missing an area that's concerning.
That's great. Thank you. Just in the interest of time, I am gonna, if you have a couple minutes where you could answer questions directly in the Q&A, that would, I think, be really helpful. Like I said, there are some really wonderful questions in there that, they always say if one person's thinking it, multiple people are thinking it too. So would love to have your thoughts on those. And just want to thank you again for your time.